No, no. Before the yes. Now come to brief history of dual antiplatelet therapy. Now first it starts with 1998 with the era of ISR, instant thrombosis. Then first generation DEX, Cypher, Texas was launched in 2003, 2004. Then came the era of thrombosis. Then came the second generation, Giants V stent was approved in 2008. Today we have safer stent platforms, more advanced understanding of DAPT cessation, experimental approaches, that is shorter duration and withdrawal. Now, on the other hand, in the era of thrombosis, the ARC paper came in 2006 and 2007, defined the optimal approach to lower early post-PCI thrombosis, recognized late stent thrombosis, identified risk factors of stent thrombosis, particularly DAPT cessation. Then came the bleeding awareness, that is the BARC 2011, that is the Bleeding Awareness Research Consortium. That is the recognized importance of bleeding, variability in risk or impact of bleeding. Now, the equipoise came then the ESC-AHA guideline, updated guidelines were in 2014, 2016, 6 months post DES, dual antiplatelet therapy, 3 months in more bleeding cases. Next. So, when we, in post-PCI cases, our aim is to reduction of ischemic events, not at the cost of increased bleeding rates. Next. So adverse impact of bleeding on prognosis in patients with acute coronary syndrome. First alarm came in 2006. Bleeding is bad. So it came in circulation 2006. You see the life-threatening bleeding has got tremendous impact on mortality. Major bleeding has got tremendous impact. Minor bleeding is of not very importance. Next. Impact on bleeding on mortality on PCIC. On 30 days, it is if bleeding occurs, mortality rate is 18.57%. If it doesn't occur, it is 3.7% for minor bleeding. After 13 days, it is 9.6% and 3%. It came in American Journal of Cardiology 2011. Next. No favorable net outcome for long-term DAPT after complex PCI in patients with high bleeding risk. Now, on the left side, you have the patients which are the non-complex PCI and non-high risk bleeding. The long-term DAPT is advocated, it's better. On the right-hand side of your right-hand side of the central line, we have got non-complex PCI with high bleeding risk, complex PCI with high bleeding risk. Here again, DAPT, shorter DAPT is better. There is no impact on this total outcome. Next. Same impact of total outcome, be it short or long. With mortality persistent after multivariate adjustment with the risk with TIMI bleeding score did not, whereas TIMI bleeding score did not. This suggests that bleeding assessed with clinical criteria is more important than assessed by laboratory criteria in terms of outcome. Next. Introduction and validation of the BARC criteria. BARC is the Bleeding Academic Research Consortium, and you see the BARC 3 onwards, the strongly associated bleeding is strongly associated with 2 years mortality. Next. So evolution of DAPT duration. So in 1995 it came the first generation stent. Sorry. So the duration of DAPT was assessed in different trials for over a long period of time, and 12 months DAPT for the first generation stent, and late 2000 entry of the second generation stent came into the market, and the duration of DAPT was shortened. Next. Hello, there is some problem in the slides.
Can you see my slides?
I'm coming, please.
Okay.
I'm coming.
Okay.
Leave. Can you hear? Okay.
Yes, yes.
So, what is the minimum duration of DAPT after PCI? We have got number of trials. Excellent trial in 2012, Prodigy trial in 2012, Reset trial in 2013, and this optimized trial 2014, Security trial, Research Reset trial, and Italic trial 2014. No advantage of prolonging DAPT beyond 6 months in reduction of thrombotic risk and contemporary DES application. Next. So this study 12 or 30 months of dual antiplatelet therapy after drug-eluting stent. So is there a benefit of extending DAPT beyond 1 year? So after 12 months, randomization was done, thienopyridine plus aspirin, placebo plus aspirin, and it was observed up to 30 months. Next.
Hello.
So DAPT results efficacy. Stent thrombosis, MACE. See, in both the arms it was almost the same. Next. So therefore, an individualized approach based on ischemic versus bleeding risk assessment was the need of the hour. Next. So development tools for decision. How long to use? We have got precise DAPT before 1 year, from the start to 1 year, DAPT score after 1 year, and Paris score, which is published in GAC 2000 16. Next. So recently there has been more recognition of trials that withdraw rather than add to current treatment. Do current clinical trials meet the society's need? So we need clinical trials that can investigate the withdrawal of certain established medication to see whether such withdrawal induces patients benefit, harm, or no difference compared to continued medication. This was published in American Journal of Cardiology by Stuart Pocock and Bernard Gush. Next. And what they say, can we safely withdraw aspirin when novel, more potent P2Y12 inhibitors are used? Next. So we have got number of trials. See, global leaders trial, investigational arm, ticagrelor up to 24 months, aspirin 1 month. Control arm, ticagrelor or clopidogrel up to 12 months and aspirin thereafter. We have got stop DAPT2 trial, 3,000 patients. Investigational arm, prasugrel or clopidogrel. Then clopidogrel continued and aspirin after 1 month. Control arm, prasugrel or clopidogrel. Then clopidogrel up to 12 months and aspirin thereafter. Smart choice, 3,000 patients with stable coronary artery disease and SES. So investigational arm, ticagrelor or prasugrel or clopidogrel, 12 months and aspirin up to 12 months. Then there are and 12 months. Control arm is the ticagrelor, prasugrel or clopidogrel and aspirin up to 12 months and investigational arm up to 3 months. Twilight trial, I shall come to it. Investigational arm, ticagrelor continued up to 15 months and the aspirin up to 3 months. And the control arm, ticagrelor and aspirin is continued up to 15 months. TICO trial, investigational arm, ticagrelor up to 12 months and aspirin up to 3 months. Control arm, ticagrelor and aspirin up to 12 months. Then stop DAPT2 SES trial, 3,000 patients with SES, investigational arm, that is the prasugrel, clopidogrel or clopidogrel, then continued up to 60 months and the aspirin is only 1 month. And ASSET trial, 2,000 patients with stable coronary artery disease, investigational arm with prasugrel. Next. So long-term treatment with ticagrelor monotherapy for 23 months following 1 month DAPT after PCI in complex clinical scenarios. Specified subgroup group analysis from global leaders trial. Next, what they say. So all newcomers, PCI population 15,991, 1:1 randomization, open label design, 130 centers worldwide. Experimental strategy is that SES patients with CAD, aspirin 75 milligram to 100 milligram up to 1 month, and then along with ticagrelor and the continued ticagrelor 90 milligram BD up to 2 years. And then reference strategy, SES, unstable angina, STEMI or STEMI, ticagrelor 90 milligram BD up to 1 year, along with aspirin continued, or clopidogrel 75 milligram day up to 1 year and aspirin continued. And here in upper arm, ticagrelor 90 milligram BD up to 1 year and aspirin is continued. Next. So what they show in SES, they show there is little difference between these two arms so far as the bleeding risk is concerned. A stable CAD is almost the same, but in SES there is big difference. See, about 2.39 versus 1.5. Bleeding risk is substantially reduced when you use single antiplatelet therapy compared to dual antiplatelet therapy. Next. Again, that is the bath 3 to 5 bleeding up to 30 days, from 31 days to 1 year, and from 1 year to the end of follow-up. Again, reference arm by experimental arm. In ACS patients, see bleeding risk there is significant difference with single arm, single antiplatelet compared to dual antiplatelet. Again, simple and the in SES and stable CAD, it is almost the same. Next. So what they conclude? There is no significant interaction between treatment effect and pre-specified subgroup throughout the safety and efficacy endpoint, except BARC 3 to 5 bleeding in SES population that benefits from ticagrelor monotherapy, whereas stable angina does not. So, in post-SES patients, after stent implantation, ticagrelor monotherapy reduces the chance of bleeding significantly compared to dual antiplatelet therapy. In stable coronary artery disease, it is the same. Ticagrelor monotherapy appeared to reduce the risk of bleeding without an increase in the ischemic event when compared with standard DAPT in SES patients. So, why it is important? Ticagrelor monotherapy following 1 month DAPT may reduce the risk of bleeding in SES patients, and it seems safe in various clinical scenarios: female, elderly, diabetes, obesity, COPD, and renal function impairment. Next. So, uncertainties surrounding the use of aspirin in secondary prevention. 3 major arguments challenge the use of aspirin in secondary prevention in combination therapy with other antithrombotic drugs. Number 1, bleeding risk is higher, increased risk of intracranial and extracranial bleeding, especially in combination with other antithrombotic drugs. Now, novel antithrombotics are available. The availability of newer compounds with potent antithrombotic efficacy could make the use of aspirin no longer necessary. And the risk reduction. Contemporary drugs favor after baseline individual risk of the cardiovascular events, translating into the relative benefits of aspirin into smaller absolute effects. So aspirin use over the long term is very minimal compared to the other novel anticoagulant effects. These are the major 3 arguments which have been put forward for the reduction or stopping aspirin early after treatment of stent implantation in patients with SES. Next. Ticagrelor with aspirin or alone in high-risk patients after coronary intervention in acute coronary syndrome. This is Twilight SES trial. It was published in 2019 June-July. Next. So, randomized population, it was randomized decision done in about 7,190 patients, 187 sites across 11 countries in North America, Europe, and Asia. In India, contributed almost 610 patients, that is 8.6%. It was a worldwide trial. Next, of a huge trial. Next. So, study design, randomized, double-blind, placebo-controlled trial in 187 sites and 11 countries. High-risk patients underwent PCI and were treated with ticagrelor plus aspirin for 3 months. Event-free and adherent patients were randomized to aspirin versus placebo and continued ticagrelor for additional year. Number of patients were 4,614, and ticagrelor per aspirin was continued for 3 months, and then ticagrelor per placebo was continued for 1 year. Next. So, Twilight SES, BARC 2, 3, and 5 bleeding. See, in combination, ticagrelor per aspirin, it was 7.6%, but ticagrelor alone, it is 3.6%. There is significant reduction in bleeding. Next. So, that is death, MI, or stroke, ticagrelor plus placebo or ticagrelor per aspirin, 4.4% or 4.3%. Same in both the groups. Next. So, key learning from Twilight SES trial. Among patients with NST-SCS undergoing PCI with DACE and who have completed 3 months course of DAPT with ticagrelor plus aspirin, continued treatment with ticagrelor significantly lowers clinically relevant and major bleeding without increasing the risk of ischemic events over 1 year. The effect of ticagrelor monotherapy was respect to bleeding and ischemic events is uniform across different levels of risk. Results is unchanged in patients presenting with unstable angina or NSTMI. Overall findings are concordant with the results of the primary trial. Next. So next comes the TICO trial. It was presented in SCS this year or in April, to test whether ticagrelor monotherapy after 3 months DAPT improved upon ticagrelor based 12 months DAPT for SCS undergoing PCI with ultra thin bio-reabsorbable polymer sirolimus eluting stent. In terms of net adverse clinical events, that is the MACE and risk of ischemia and bleeding. Method: patients undergoing BP, that is the CES implantation for SCS treatment will be randomized 1:1 fashion. Ticagrelor monotherapy group after 3 months of DAPT or 12 months DAPT group. Primary endpoint NACE with 12 months of percutaneous coronary intervention, which include major adverse cardiac and cerebrovascular events are taken into account. And the bleeding risk was defined by TIMI bleeding score. Next. So patients with that is the BP is a sirolimus eluting stent. The 1:1 randomization was done. Primary endpoint net clinical adverse events at 12 months plus TIMI major bleeding plus major adverse cardiac and cerebrovascular events, that is all death, MI, stent thrombosis, stroke, and target vessel revascularization. Ticagrelor monotherapy after 3 months of DAPT or ticagrelor based that is the DAPT. Ticagrelor monotherapy, that is the 3 months DAPT, and then aspirin discontinued and ticagrelor was continued for 12 months. Next. Primary outcome, NACE, net adverse cardiac events at 12 months. At 12 months, you see that the ticagrelor monotherapy after 3 months of DAPT was better compared to the ticagrelor based 12 months DAPT. At 3 months landmark trial, also that showed ticagrelor monotherapy was better so far as the cumulative evidences of death, MI, stroke, etc. is concerned, especially the bleeding events. Next. Major bleeding, I can see there is significant difference. 3% ticagrelor based 12 months DAPT, or 1.7%. It is the with monotherapy of ticagrelor alone. At the end of 360 days, or if you consider after 3 months onwards, there is the curve is separating, and the ticagrelor bleeding risk was 1.6% with dual therapy, 0.2% only with monotherapy. Next. Major advanced cardiac and cerebrovascular events. That is, you see, at 12 months, clinical endpoint almost same, 3.4% versus 2.3%. Again, if you see the curve separates after almost 5 months, and there is again significant difference, 2.1% versus 1.2%. Next. So key learning from TICO trial. Among patients treated with ultra-thin biodegradable polymer sirolimus eluting stent for SCS, ticagrelor monotherapy after 3 months DAPT showed a significantly lower risk of net adverse clinical events than currently recommended ticagrelor based 12 months DAPT. These findings indicate that ticagrelor monotherapy could be an optional strategy, balancing both ischemia and bleeding risk for patients with SCS treated with ultra-thin biodegradable polymer sirolimus eluting stents. Next. Final remarks, two independent trials reaching the same conclusion. In these two studies, with two groups of patients at higher risk of ischemic outcomes, ticagrelor monotherapy after 3 months of dual therapy showed a comparable ischemic outcomes as well. These findings indicate that ticagrelor monotherapy could be an optional strategy that balances both ischemic and bleeding risk in patients with ACS. Tico and Twilight used the latest second generation drug-eluting stents, which may have better safety and allows us to get away with the less antiplatelet therapy. The use of newer generation P2Y12 inhibitors, ticagrelor, allows an aspirin-free antithrombotic management following coronary stenting. Next. So the thrombosis blood bleeding risk. On one hand, you have anemia, prior bleeding, oral anticoagulant therapy, cancer, planned surgery, renal insufficiency, etc. On the other hand, you have diabetes, ACS, complex PCI, prior stent thrombosis, renal insufficiency, etc. Next. Tackling residual risks. It's not all about antiplatelet therapy. Implementing bleeding reduction strategies does not take away the need of still tackling the residual risk. Newer avenues for research and development. What are those? Next. This is a very important and very informative slides. You see, the lifestyle modification, guideline directed medical therapy. We have to see the lipoproteins, inflammation, and post-ACS patients, metabolism, platelets, and coagulation. These are the residual targets, residual risk-lowering therapies. In lipoproteins, you have ezetimibe, PCSK9 inhibitors, omega-3 fatty acids. And in inflammation reduction, it is the canakinumab, that is the drug which reduces the inflammation. Methotrexate and colchicine. Metabolism, that is a diabetic group of patients. We have got SGLT2 inhibitors, GLP-1 agonist. Antiplatelets, extended DAPT, low dose ticagrelor. Anticoagulation, that is the low dose rivaroxaban. Where is to be used? See in lipoproteins, standard lipids, example LDL, HDL, TG. Advanced lipid tests, LPA control is increased HDL, efflux capacity, genetic risk score, atherosclerotic imaging. These are the defined precision making tool. Then in inflammation, you have HSCRP reduction, biomarkers of inflammation reduction, T cell and immune dysregulation, and the clonal hematopoiesis, systemic inflammation disease, that is example psoriasis. And in metabolic, you have prevalent type 2 diabetes, HbA1c reduction, HOMA-IR reduction, BMI reduction, visceral adiposity reduction, liver fat reduction. Then extended DAPT, you have antiplatelet risks across the platelet function testing and pharmacogenomics. That is, we use DAPT score, Perry score, precise DAPT score, as I have told and I have said. That is for 1 year from the start we have got precise DAPT. After 1 year we have got DAPT score. How long is to be used and what dose to be used. And in coagulation cascade, in patients with peripheral vascular disease, prior VT, that is the thrombophilia, bleeding risk, etc. We have got the newer drugs, that is the rivaroxaban. We use it in polyvascular diseases, patients with multiple previous MI, multiple stent implantation, peripheral vascular diseases, all those patients, rivaroxaban in a lower dose, 2.5 milligram PD along with aspirin, 7.5 milligram. So antithrombotic, that is in the form of antiplatelet, is not the only answer to reduce the overall risk of stent thrombosis and subsequent target vessel revascularization or non-target vessel revascularization. Next. So thank you very much for listening us, and we conclude by saying that the antiplatelet therapy with newer drugs like ticagrelor can be used in a single drug of post-ACS patients after 3 months, and in some cases after 1 month of PCI. And in elderly population, we we prefer clopidogrel. More than 70 years or 75 years of age, we prefer clopidogrel alone in patients of in place of ticagrelor to reduce the chances of bleeding. Single drug. Thank you.
Sir, there are some few questions in chat box.
Yes, loudly.
Sir, there are some few questions in chat box.
Yes, you tell one by one.
Uh, Sir, there are chat box option. You can read by them.
No, I'm not getting it. You read it.
Okay, sir. You should aspire as the backbone in antiplatelet therapy. However, recent evidence are suggesting aspirin-free antiplatelet therapy in long term. Please share your opinion on the same and how to categorize these patients.
So very nice question. So at this point of time, we prefer to go by guidelines. Guidelines do not say 3 months of antiplatelet, three months of dual antiplatelet, then single antiplatelet. So in high bleeding risk patients, in ACS patients, we say it is 3 months, it is 6 months, and in very high bleeding risk patients, it is up to the 1 month, and then they continue with the single antiplatelet therapy. So guideline do not say in routine cases you use single antiplatelet therapy in the form of ticagrelor after 3 months of dual antiplatelet therapy. It is only at this point of time in selected cases with high bleeding risk. Otherwise, we continue dual antiplatelet therapy for 12 months and then we continue single antiplatelet therapy in the form of aspirin. So far, guideline do not revises it.
Sir, do you believe in crushing the ticagrelor tablet and use it as loading? Does it increase the
Loudly, speak loudly, madam.
Do you believe in crushing the ticagrelor tablet and use it as loading does to increase the antiplatelet activity in STMI? Hello, sir. Am I audible?
We always load the patient with ticagrelor more in post-operative period.
Sir, another question is what is the current status IV antiplatelet therapy during PCI?
Yes, there is canglilor is there. It is used in Western countries in some selected patients who cannot tolerate these oral drugs and others, but it is not available in our country. Yes, canglilor is an option for IV and antiplatelet therapy before PCI. Yes.
The recent ECS guidelines in the NSTE SES patient has given priority procedural over ticagrelor. What is your opinion on the same while
Yes. That is the only study that showed that showed prasugrel is superior to ticagrelor. But in our clinical practice and the meta-analysis which we follow in our day-to-day practice, they show that the ticagrelor and prasugrel is almost the same. But the ticagrelor, there is the prasugrel use. We have to see always see the three points. That is the age of the patient and the weight of the patient and prior stroke. That is not always possible to collect the data in ACS patients. That's why we we take ticagrelor. That can be used in a wide variety of patients without any these contraindications.
So another question is what should be the antiplatelet strategy in patient with F undergoing multivessel PCI?
A
Undergoing multivessel PCI.
AF with multivessel PCI.
Yes.
Yes. So guidelines as of today, we use 3 drugs. That is the dual antiplatelet therapy and the oral anticoagulation. That is in the form of rivaroxaban or apixaban or this dabigatran. So long the patient is stable in the hospital, and then 1 month therapy with this dual antiplatelet therapy. That is the clopidogrel plus this NOAC, and then it is the NOAC only. Previously, it was 1 month therapy with 3 drugs, 1 year therapy with two drugs, clopidogrel and this NOAC, and then NOAC only. But now it is shortened to 1 month only.
Recent Sir, recently US FDA has approved Tricagolar 60 mg for the primary prevention of high risk CAD without or with diabetes. Are you implementing in medical management for Indian
No, no,
patients?
no, no, no. No, in primary prevention, we do not use this group of drugs because we have not sufficient data that it prevents the that is the ACS or this acute coronary syndrome in patients with diabetes. And this the three trials also failed to show efficacy of aspirin. So unless there is severe indication, there is a concrete indication of using these antiplatelet drugs, we do not use routinely in patients with diabetes. In high risk patients, you can use it, but yes, you can use it in very high risk patients. 60 milligram of ticagrelor BD we use post ACS patients who need dual antiplatelet therapy for a long time after 1 year. That is the 60 milligram ticagrelor BD along with 75 milligram of aspirin for 3 years.
Does genotype mapping with clipperdragal is a practical approach in India?
No, it is routinely not advocated, and also it is not feasible to do this. Whether it is the genotype mapping in very highly selected patients who have got recurrent stent thrombosis and others, it can be used. But at this point of time, we have got better drugs in the form of prasugrel or ticagrelor, and we use it in place of clopidogrel rather than going for genotyping.
Okay, sir. So there are no further questions. So, with your permission, shall we conclude this session or we can wait? Hello. So there are
Yes,
no further questions. So can we
uh,
wait or can we conclude the session?
yes, you can conclude.
Okay, sir. So on behalf of organizer, I would like to thank you for your insightful and educative talk. Thank you, sir.
Thank you.